Hi, everybody. You are listening to Judging Meghan with your host, Meghan Judge. I want to thank all of you for your patience over the last month that I've kind of had some episodes revisited. I was, as you know, from my last episode that I just re-released, I've been going through a little grief of my own. And I'm happy to be back. And to be honest, I'm so, I shouldn't even say excited, but I'm thrilled to talk about the topic that we're going to talk about today. So Dr. Mark Horowitz is the world leading expert and author on antidepressants and benzo withdrawal. He is the author of the only clinical guidebook on deprescribing, the second best-selling psychiatric book in the U.S. He is co-founder of Outro, a neuroscience-based digital clinic for tapering off antidepressants, which was recently featured on NBC News. He recently in May published his most recent peer-reviewed study on psychiatric research in May of 2025, showing a link between duration of antidepressant use and the severity of withdrawal symptoms. I am sorry I butchered that I was clearly reading it, and I apologize for my poor reading today. But I'm thrilled to have you on. Welcome to the podcast.
Thanks for having me on, Meghan.
So what do you want me to call you? Dr. Mark, Dr. Horowitz? Let's get real here.
That's right. That's my father's name. You can call me Mark if you like.
Okay, I'll call you Dr. Mark. So, or Mark. So I think that this topic is so important. So many of my listeners come here and I talk all the time about my own history of, from childhood, going through a really traumatic childhood, being put on medication early, on and off medication throughout my life. At one point, I'm very open with this, I was suicidal. I was on Zoloft in 2020. And then I kind of tapered myself off of it. And I haven't been on anything in the past several years. And that's just a choice for me. Everybody has their own choice when it comes to their mental health, and some people need it and it's kind of like an arm that they need to be on medication. But what I love about what you do is that it's not a life sentence, correct? So Dr. Mark, I just want to start with why you decided to write this book, your recent book, and why you're so passionate about people not being hooked on these medications. Let's start there.
Sure. So I wrote the textbook you're referring to as the Maudsley Deprescribing Guidelines, and I set up the clinic. You mentioned Outro Health. I've done something similar in the UK, all for the same reason, to give people access to information and support to help them come off antidepressants so they can avoid what I went through when I came off my drug. So, like 1 in 6 people in the Western world, I was on an antidepressant. I was on actually Lexapro or escitalopram, a very common antidepressant in America. I took it from my early 20s. Again, like the rest of the world, I went through a difficult period. I wasn't very impressed with my university course. I had issues when I was younger. I was given an antidepressant. I didn't actually find it very helpful, but I took it because I thought these are the sort of things that people like me should take. And I took it for many years, and I went into medical school and I trained as a psychiatrist, and I did a PhD in how antidepressants work and what causes depression, because I was obviously in the cliche trying to solve my own problems as people do. Towards the end of my PhD, I read a paper about withdrawal effects from antidepressants, that people get brain zaps and headaches and dizziness and panic attacks. And I found that startling to read, because I had not been taught that in my training. I sort of knew that drugs like benzodiazepines and opioids and heroin cause withdrawal effects. And that to me said two things. One, a drug that causes withdrawal effects means you get used to it. That's tolerance. The more tolerant you get to a drug, the more your body misses it when you stop it, like caffeine, benzos. And I thought, I at that point had been on an antidepressant for 13 years. I thought, how could it be doing anything still if I've been on it, if it causes tolerance over time? That's number one. And number two, all those drugs that I mentioned are not very good for you in the long term. Opioids, benzodiazepines, alcohol, cigarettes, things that cause withdrawal. And so it made me, take a double take. What have I been taking? As it happens, I had a lot of health problems whilst taking antidepressants. I was very tired all the time. I had issues with memory and concentration. I was very foggy. And I went, I come from a very medical family. I've got a very medical orientation. I've got 6 degrees in science and medicine. So that's sort of my approach to the world. I'd seen lots of doctors. No one had really been able to work it out. I was given lots of diagnoses. I was given lots of other medications. Part of me thought, is this the antidepressant? And that was basically reading about withdrawal effects from the drug was the stimulus to me to try to come off the drug. And I came off over a few months. I thought it was extremely slow because the guidelines said come off over a few weeks. I used a liquid version. I was working in a fancy laboratory. I used special syringes and weighing machines. I'm a kind of peak nerd. And I still, when I got down to a very low dose, my life exploded. I had trouble sleeping. I would wake up in the mornings in full-blown panic, like I was being chased by a wild animal. And that would last for hours and hours of the day. I was dizzy. That went on not just for a few days, but for a few weeks. And I, for the first time in my life, I thought, I cannot live like this. And I ended up going back on the medication. And at that point, I realized I'm now on this medication, not because it's helpful, but because I can't stop it. I'm now trapped on it. You use the word hooked, which is supposed to be for addictive drugs. Mm-hmm. This sort of sounds like addiction, but the correct terminology is physical dependence, although it sort of sounds academic because I couldn't get off the drug. So in some ways, it's not that dissimilar. And I guess, first of all, I thought, oh my God, I'm so unlucky. I've had this horrible reaction to coming off. I didn't for a single second think this was me, my original issues coming back. When I was 21, I was pessimistic. I was miserable. I was not having a good time in life. I'd never had 10-hour-long panic attacks. I'd never been dizzy. I never had trouble sleeping. It was a completely different beast that got me when I came off the drug. So I knew it was a withdrawal syndrome. It was obvious. What I had at 21 was a 3 out of 10. What I had when I came off this drug was a 10 out of 10. I guess the next step for me was realizing that it wasn't just me. I did a Google search and I found, a dozen people like me. Then I found hundreds. And eventually I found tens of thousands of people on different peer support groups, Facebook sites, Reddit, sites with the exact same story. I thought, this is not just me being unlucky. There's something going on here. And I ended up writing an academic article about what I'd learned from a lot of these websites that described how to come off the drugs. With the main points I can elaborate further is coming off very slowly, going down to much lower doses than normal tablets or capsules allow, because tiny doses of these medications have large effects. It's called hyperbolic tapering. I can show you a few graphs or describe it. The essence being that the last couple of milligrams of any drug are much harder to come off than the first few milligrams because of the way drugs affect the brain. And I sort of had this thought, I have 6 degrees in psychiatry, medicine and science, in antidepressants in particular. And yet I'm learning how to come off my drug from a peer support site, from retired engineers and homemakers and truck drivers. How come psychiatrists don't know this? How come doctors don't know this? And that's why I'd written the paper. And I guess I spent the last 6 years since that happened, a bit trying to get the word out to doctors and researchers with some mixed success to try to stop all the harm that's happening to people like me who are on these drugs, who when they come off the drugs, are told this must be your original condition. It can't be the drugs. These are very easy to stop. You must need the drugs. And so there's this, huge amount of gaslighting, not because doctors, intend it, but they're not well informed about these issues. And that leads to a lot of harm. And that's why I set up Outro Health in America and written this book to try to get people more educated on this topic.
Well, let me ask you a question. So I would assume it's kind of like if you are a psychiatrist, you go to school for this, obviously, it's not a topic that you probably learn getting off the drug, correct? Yeah. So that's part of why the focus of this is because psychiatry, you go to a psychologist to talk about, your mental health and try and work through it. And then the second step is to go to a psychiatrist. And the psychiatrist's job, for my listeners, I'm not telling you this, is to prescribe medication. So my thoughts on that are
it shouldn't
correct.
Be,
correct me if I'm wrong. That's what I wanted to know.
Right. Psychiatrists would say, no, we're biased, psychosocial. We look at all elements of people's mental health. But in practice, 98% of interactions with a psychiatrist involve a prescription of medication. So, yes, that's exactly what happens in practice, exactly what you've said, that prescribing is the main thing that psychiatrists do. You're right. In my training, I received thousands of lectures on how to start drugs and no lectures on how to stop drugs. My little gag is the first lecture that I heard about stopping psychiatric drugs was one that I gave because it just wasn't in the curriculum.
Okay, so that needs to change. It's the same thing. I've done episodes about hormones, and I'm gynecologists, and they say to women, you don't need HRT. You don't need, because they don't understand it, right? A lot of they go to school to deliver babies, and then they don't go to school for, to become a urogynecologist and do the additional training on hormones. It kind of reminds me of that kind of thing, stay in your lane. Whereas this is a perfect example of, we have a mental health crisis in our country and all over the world right now, but I'm in the United States, and England and all different kinds of countries have these same mental health issues when it comes to our phones and our kids and the addiction and all the things that we have right now. For children, what you said, this really struck me, because I feel like a lot of times kids are put on an antidepressant and their brains are not fully developed yet, right? So can you kind of touch on that, what your thoughts are on kids being on medications?
Sure. And this comes down to, so I'll just say on the point about education, I think this is even more fundamental than that. Car regulators mandate that if you sell a car, that the car should come with brakes. But in psychiatry, doctors are trained to prescribe medications, but not to stop them. If this was to do with cars, there'd be legal issues straight away. But in medicine, you sort of learn half of what's important. When it comes to medication and the effect on children, the answer is we have no idea, because studies haven't been done. 97% of studies of antidepressants go for 8 to 12 weeks. So there hasn't been a lot of attention paid to what are the long-term effects. So, a famous professor of psychiatry has described what's happening in America and around the world as the largest open-air experiment ever conducted. We don't know what exposing developing brains to strong chemicals does. I think there's a couple of points to be made about that. One is, antidepressants have been sold as normalizing a chemical imbalance. I don't know if you've heard that sort of line, that people's mental health problems are caused by abnormal chemicals, the drugs fix them. The first thing to say is, of course, that's completely false. They've never found a chemical imbalance in depression or anxiety. It was a hypothesis many decades ago. Lots of research has not found that that's what occurs, and most psychiatrists, if pressed, will say that's not accurate. There's no evidence for that. But what that does is it presents medications like antidepressants as being very safe, because if a drug normalizes an imbalance, well, of course that makes sense. If you don't have enough thyroid hormone and you give thyroid hormones, there's no long-term safety issues with that, because it's a normal hormone existing in the body. But when you realize that what antidepressants are doing is they're changing the chemical balance of a normal brain, they're increasing serotonin or norepinephrine, then you start to realize it's quite possible that they can cause unwanted effects in the long term. And there are lots of signs of that. So, we know that people put on weight, that people become tired, that people don't sleep as well, that there are impairments of memory and concentration. There are serious sexual problems that occur to people taking the drugs. We know that sometimes those issues don't go away when people stop antidepressants. Is that more prominent in children because their brains are developing? Are they more susceptible to drug influences? Are their hormonal systems more susceptible? The answer is unsure, but it may well be yes. We know that animals that are given, so they use mice and rats to do sort of experiments. We know that young animals given antidepressants do not go through normal sexual development when given antidepressants because antidepressants affect their hormonal systems. Is that the same? Is that occurring in children? Again, we don't know the answer, but given the animal data, it's a sort of a worrying prospect. We do know that antidepressants have a profound numbing effect on people's emotions. That's probably why they work if they work for people. So if you're very anxious, you're very depressed or very panicked, turning the volume down from a 10 to a 3, can be a relief. But it also can profoundly affect the way that you interact with others, your relationships, intimacy. So we don't know what is the effect of numbing, emotions in a teenager or a young person whilst they're growing up. When we're learning how to interact with the world, that's a big part of, maturing. So I guess all of those are unanswered. What is the direct effect on the brain? There is some research showing that in long-term antidepressant users, that their brains are slightly shrunken compared to equally depressed people who are not on antidepressants. So it's not a randomized trial, so it's hard to be sure it's the drugs. But there are lots of signs that long-term effects of these drugs on the brain, are not positive. We don't know the effects psychologically of having your emotions numb. We don't know the effects on the hormonal system that can be affected by these drugs. So I think there are a lot of unanswered questions. We do know when people come off these drugs, they have huge problems. So there are.
Okay, this is not good news and very terrifying to me. But this is the thing. I've been doing this podcast for 5 years. I've had tons of doctors, psychologists, psychiatrists come on, and so many of them are like, okay, you're for example, a bipolar person that's homeless. I did an episode about this where this man was on the street and he needed that medication, and he's completely gone from being on the streets to taking his meds, and he's doing okay now. So what would you say to something like this? I know, because I have not read the book, but there's got to be other solutions. So what are the solutions to these problems that people are on these medications? They need them. What do you do?
So I'll take a step back and kind of talk about what the drugs do. So I won't try to solve all mental illness in the next 30 minutes. But
I would like for you to do that, please, because that's the whole point. I'm joking. I kid. Yeah. Okay.
I think it's worth thinking about what psychiatric drugs do, what they're capable of doing, what they're not capable of doing, and what they, and their effects on our brains and bodies. So there's two ways of thinking about psychiatric drugs. One is called the disease-centered model, and that's often presented. The disease-centered model goes something like this. It's a bit taken from physical health medications. When you get a pneumonia and a lung infection, you're coughing and you've got a fever and you feel terrible, you take an antibiotic and the antibiotic kills the bacteria causing the infection, you feel better. The drug you're taking is fixing the underlying problem in pneumonia and you feel better. Insulin is replacing a lack of it in diabetes. Those are examples of the drug kind of getting at the cause of the disease. In psychiatry, psychiatrists and drug companies especially like to talk about psychiatric drugs in the same way. They even the word antidepressants sounds a bit like an antibiotic. It sounds like it's getting to the cause of depression, solving the chemical imbalance, and that's why you feel better. But, we haven't found that depression is caused by low serotonin or a specific chemical imbalance. So that is kind of a just so story that came from the marketing department of drug companies. When you look at what drugs do, there's another way of looking at things. It's called the drug-centered model. The drugs that we take for psychiatric reasons cross the blood-brain barrier. That means they get into the brain and they affect the way that we think and that we feel. An analogy would be something like alcohol. So if you're very anxious and you drink alcohol and you go to a party, you feel better because you're a bit more relaxed, you're a bit disinhibited, life is easier at the party in terms of anxiety. The alcohol has worked to reduce your anxiety, but it hasn't worked by solving the underlying cause of your anxiety. It's superimposed the effect of alcohol on whatever your anxiety is. You wouldn't say that social anxiety is caused by an alcohol deficiency. We all sort of understand that the drug has been imposed on what we feel. And I think that's a much more accurate way to understand what psychiatric drugs do. No drugs can fix the underlying cause of bipolar or anxiety or depression. What drugs can do is superimpose things that can be helpful. They might, a benzodiazepine can make you feel more relaxed. An antidepressant is very numbing. If you're very upset, it can turn down your emotions. But I think it's worth understanding it's doing that by disrupting the normal functioning of the brain. It's not fixing the underlying imbalance. Like alcohol creates an abnormal chemical balance in the brain, so are psychiatric drugs. That's not to say they're not, useful. I'm not arguing we should never use psychiatric drugs. If people are, not sleeping and, very manic, it's very useful to have something that will calm them down and make them sleep. Mm-hmm. So I'm not saying there's no use for it. But I do think we get into trouble when we mistake these drugs that can be useful in the short term as long-term cures. So, for example, if you're very upset because of divorce, because you've lost your job, and you use an antidepressant that makes you feel better in the short term, I don't think the jump then to you need to be on this drug for the rest of your life because it's solved this, it's helped you get through this rough period in your life makes sense. If you think about it as fixing a chemical imbalance, that does make sense. If you're a diabetic, you need insulin. But I don't think that analogy holds at all well to psychiatric medications and conditions. So what is useful in the short term, I don't think has a strong relationship to what would be useful in the long term. And alcohol, again, provides a bit of a useful analogy. You wouldn't say to somebody, because alcohol's helped you get through this party where you've had terrible anxiety, you should have half a bottle of whiskey every day until you die, because it'll prevent anxiety coming back. That makes no sense, because we know that alcohol in the long term causes liver problems, actually worsening anxiety, and all sorts of other health problems. I think if you look at psychiatric drugs through that, what's called that drug-centered lens, it all makes more sense. Yes, drugs that sedate or numb or make you less anxious can be helpful in the short term. It may be different in the long term. Drugs wear off. That's tolerance that I already mentioned at the beginning. If you use the drugs in the long term, you'll get withdrawal effects. So the longer you use them, the more you're going to pay when you stop the drugs. And so it might make more sense to use them short term at lower doses, stop them when you don't need them. And it's possible that a drug that was helpful for you in the short term may cause more harm than benefit in the long term, like alcohol. I'm not saying that psychiatric drugs are like alcohol. What I'm saying is it acts as a model to understand something, that just because something is helpful in the short term doesn't tell you about its long-term effects. And I think one of the reasons why a lot of doctors are very, bullish, very pro on these drugs is they've been very convinced by short-term studies that drug companies do. I was very, I was a bit very much taken with psychiatric drugs in my training because I was shown study after study about them being effective and being safe. It was really only when my world was turned upside down by the drugs that I kind of came back and went, how have I just been punched in the face by something that was so safe and effective? And the main thing that I realized was I had been shown again and again 8 to 12 week long studies. And, I had been on the drug for 13 years. So that's a very big mismatch. If you looked at 8 to 12 weeks of someone on alcohol, they might be quite happy. They might be functioning quite well. They don't have liver disease by then. They don't have any, dementia or any of the negative effects. And so I think that there's been a lot of misleading of the public and professionals by drug companies relentlessly focusing on short-term studies that tend to exaggerate benefits and underestimate harms. And I think that's why there's such a mismatch between what happens with long-term treatment and what looks so wonderful in these short-term studies.
Okay, well, I like that we reiterated that you're not anti-meds like for the short term, correct? I just want to clarify that.
Yes. So like I said, there's, of course, there's benefits to medications. I'm not saying not to use medications. What I'm saying is it's good to be objective about what the harms and benefits are and what happens both in the short term and the long term so people can make informed decisions about what's useful to them.
Okay. What about like an ADHD medicine? Would that fall under the same category? I'm just curious.
So, I guess the major focus of my research and my clinical practice is on antidepressants and benzodiazepines and anxiety and depression. So it's a little bit outside of my lane, but there are similar because it's a psychoactive substance.
Yeah, because they could go hand in hand, correct?
So again, I didn't talk about the evidence for efficacy of different drugs, but ADHD drugs, yes, of course, tolerance occurs. That's what happens with any drug. Your body kind of tries to counteract the effects of the drug, and so people develop tolerance. There are withdrawal effects from ADHD medications. The withdrawal effects from ADHD medications are generally not nearly as severe as for coming off antidepressants or benzodiazepines for a variety of reasons. They act on different transmitters from antidepressants. There are studies, again, people that take stimulants. I mean, everyone who's taken caffeine has sort of had some experience of taking stimulants. They tend to make you more focused on a single task. There are studies saying that in the long term, those effects, are not clear. That in the long term, people with ADHD who are given stimulants don't have as good performance in the long term at 4 and 8 year follow-up as people who are not given the medication. So there are differences between long-term effects and short-term effects.
Okay, my next question is, so from a solution-based piece of this, so what do you tell your patients? Like if you're, you want to shorten their time on medications. And I wanted to also bring up the drug companies really pushing these medications. I mean, all the commercials on TV, I sometimes wonder why anybody would want, because the side effects are always like, you might die, you're going to have diarrhea, and you're also going to, I don't know what else, can cause suicide. So you see these commercials and you're like, why would anybody take this drug? But they have to put it. So can you talk about that? I just asked 2 questions again. I'm obviously really fascinated by this. So I'm sorry if I'm overwhelming you with all these questions at once.
You're asking me about when people are starting to take drugs, what I do, or you're talking about when people want to stop drugs, what do I do?
When people, I guess I was trying to make a point that you watch TV and you see the commercials and they're all talking about these horrible side effects. And when you see the commercials, you go, wait a minute, like that doesn't sound good. And there have been, linked studies, and obviously some of these drugs can cause suicidal ideations, correct? So I kind of wanted to ask that piece, but it was in a really horrible way because I'm not doing well with my questioning today.
No, that's okay. I guess I'll focus on antidepressants because that's the most commonly used drug in America.
Yeah.
And it's also the drug I stop the most commonly. I guess when people are considering starting an antidepressant, I'm very keen on informed consent. And I think that involves talking about some of the things that I've talked about to you, how effective the drugs are, what the side effects are, how the drugs work, what the alternatives are, and how to stop the drug. Those are the 5 things that I try to cover. I want to focus on the side effects. It's funny so drug company advertising, of course, it's not legal except in 2 countries in the world. Only America and New Zealand allow it because advertising directly to consumers is considered poor form because normally you have an intermediary, a professional trying to weigh things up. I think that you should take seriously what drug companies say. The reason why they list all those side effects is because they've either been sued for those side effects or multiple patients have reported those side effects or they've seen them in studies. When I went through medical school, I was sort of taught to regard those lists of symptoms as don't worry about it. It's just written by the lawyers. Now I say to patients, this is written by the lawyers. Take it deadly seriously. They wouldn't put it in if it wasn't an issue for them. So I do think that when I was prescribed a medication, I was sort of told there's a few side effects. They'll go away in a few weeks. Don't worry about it. That is not true. Long-term studies show that side effects persist and sometimes worsen. So when people are on the drugs for a year or more, things like nausea, difficulty sleeping, daytime fatigue, I mentioned concentration impairment, memory impairment, sexual problems, weight gain, are all still present in many people. You've mentioned a kind of very high, a severe risk that especially in young people, there's an increased risk of suicidality, and that has been found in double-blind randomized trials. So it's not people's underlying depression, it's the medication that causes it. That has been found, in the trials that have been done. It's especially prevalent for people under the age of 24. We don't know exactly why it happens. We do know that young people are more likely to become agitated and anxious on these drugs. There's a condition called akathisia, which is sort of where you get this very agitated feeling, and that can lead to suicide. And people think that might be why people are more prone to either consider suicide or try it in the first few weeks of trying an antidepressant. I think that's mostly, again, brushed away by most doctors that say it will go away. That's not what the trials show. There's another line they also use. They say the reason why people are more likely to commit suicide when they start an antidepressant is because they feel better, or they feel more active before their mood improves. But no one has shown that. All these studies show is that there's an increase in suicidality in the first few weeks that young people are given these drugs. So I think it's a very serious risk. I've talked about the sexual side effects that can persist after stopping. I've talked about withdrawal effects that can happen after you stop the drugs. I think people should be very, aware of all these issues rather than being kind of, sort of jollied along onto the drugs and kind of given a very rosy-eyed, because I think that's what that was sort of what I was told to do. You sort of know this drug is good for the person, so play down the harms, encourage them to take it. I don't think that's a very ethical approach to take, because people turn around, they have these awful side effects, then they can't get off the drugs because of withdrawal effects and they feel trapped. And it's not fair because they were not given, adequate warning that this could happen to them. So I spend a lot of time talking about the negatives of these drugs. And if some people decide not to take them, that's a perfectly reasonable decision to make, because, the effectiveness of these drugs is very limited. When you look at randomized trials, the difference between an antidepressant and placebo is very hard to see. It's a very small amount, 2 points on a 50-point scale. It's not like if these drugs were wildly effective, then it might justify a lot of side effects, but that's really not the case. We also know there's a lot of alternatives that are just as effective as antidepressants for depression. I think it's also worth taking a step back. You sort of said it's a mental health crisis. And in a lot of respects, that's true. There's more and more people that meet criteria for depression. There's more and more medications being given out. But I also think that we have very over-medicalized, mood and distress. There are lots of reasons why people are upset. Your examples you gave for social media. There's lots of reasons why people are distressed in the modern world. Pressures to compete with others, to find a stable job, relationship problems, trauma, all sorts of things. And I think, for an individual, what helps them really depends on what is causing them to be distressed. If someone has relationship problems, they need some help with relationships. If they have financial problems, they need some help with their finances. When you talk about depression, it sort of makes it all sound like it's one big thing. And then we talk about what drug is most effective, or is it mindfulness, or is it some other treatment? And I think that using that very medicalized frame obscures what's happening for the individual in their lives and leads to this sort of one-size-fits-all solutions. And so I can rattle off, what the guidelines say for what are the treatments that are most effective for depression, and I can do that. But I really think
I would actually love for you to do that as an alternative, just so people, because a lot of people for years I've been talking about, you should be put on medication. I have all these doctors coming on. I was briefly, said in the beginning that I've been on medications throughout my life, and I've always weaned myself off of it because I felt like something, like I don't want to be on this forever because it was so pushed on me as a kid. Like I talk about my listeners know in 2020, I was on Zoloft and I was in the worst point of my life, but I've also done so much therapy. Like, there's all kinds of things now that people can do. There's TMS, there's all different kinds of therapy that are coming forward, ketamine therapy. So I would love for you to talk about that for the listeners as an alternative.
Okay. So I think the first thing to say is sort of what I said, that it's it depends on what is happening in someone's life. That determines what's most appropriate to help. I think all the treatments you've mentioned, all fit into that model that I mentioned before, this sort of drug-centered model. There are lots of drugs that can get people high, or sedate them, that generally wear off and generally have many toxic effects. And I think, drugs are getting more and more, people are getting a bit more desperate for a new drug, and they're using more and more potent drugs that are closer and closer to recreational drugs. And of course, ketamine has sort of jumped across that line to using, an overtly recreational drug. In England, we always have articles in the papers about kids dying from overdoses of ketamine. We have a ketamine abuse problem in the UK. And now, of course, ketamine is being used as a medical treatment. It happens in the UK that it's been banned by the health system because it's not effective according to their criteria. It's dangerous. Okay. There's an increased risk of suicides. And so it's not recommended in our health system. But in America, you have a much less regulated system, so it's much easier to bring drugs onto the market.
I'm glad that I brought this up because I have not done it, just so you know, but it's like so many people are talking about it now and like microdosing and all these other alternatives. So I'm glad I brought that up.
Yeah. I mean, I guess, people always want a magic bullet. That's sort of like, you're experiencing all this trouble in your life. The idea that there could be something you could snort or swallow, is so attractive to solve complicated problems. The drug that's become the big the blockbuster in America is ketamine or Spravato, where you snort ketamine. That's sort of been the big that's the big drug from Janssen. That's the big blockbuster that's sort of taken over psychiatry. In the studies that have been done, it was mostly ineffective. There was a single study where it had a small positive effect after 8 weeks. It causes a whole lot of health problems. It causes your bladder to stick together, and so you get a lot of trouble passing urine. In the study, there was 6 deaths in the group given esketamine and none in the group given placebo. 3 of those deaths were suicides. One of the deaths was a car accident because it obviously messes up people's hand-eye coordination. It causes a spike in blood pressure, and so people died in the study of heart attacks and one other, I think, a respiratory problem. So it is a very physiologically affecting drug. It wears off over time, and of course it has tolerance. Of course, what happens in practice is, although the studies go for 8 weeks, people get it over months and years. I know that in America it has become a blockbuster. There are ketamine clinics now giving out the drugs twice a day when it was never intended to be given that much. And I think, it's likely to cause, the Friends actor dying from it was just a very high-profile example of what happened.
Matthew Perry. No, I'm so glad I brought that up because none of this is very good news for what, it's the example of what is in our cereals, right? And in our foods in America. Like we just eat these things and everybody's like, well, why do you send our food overseas that doesn't have the same ingredients? It's just our country. But there is, there has to be a silver lining here. So I will take ketamine therapy out of it because now I'm like never going to talk about that again. And I actually was supposed to do an episode about it. And guess what? It's being canceled. So can you tell me some alternatives for my listeners that maybe are listening and they are on medications? And, you said short term, there's got to be some good news and some silver lining here.
So, I just to sort of finish off my point, because there are new drugs come out all the time. You talk about ketamine, but there's Auvelity. It's a drug which is like it's a cough. It's basically a cough. The active ingredient in cough syrup as a drug. They're also looking at opioids now for depression. So, the drugs that cause the opioid crisis. Actually, it's not even yesterday because it's still happening now. They're looking at for depression. And of course, if you take an opioid, you feel better for a few weeks. So I think if your listeners became aware that a lot of drugs that make you feel good or euphoric may not be that good for you in the long term, and psychiatry does have a tendency to run from fad to fad because they want some big new thing. It has all this distress. How do we deal with it? So I would just add that note of caution. So in the UK, to get to the what is effective, we have a government department whose job it is to assess treatments for use in the public health system. That's 56 million people. So that's very different to in America. The FDA approves drugs that go out on the market and private doctors prescribe them. We have an extra layer of, protection, if you will, in the UK. I guess people might call it a nanny state, which I'm a bit grateful for.
I'm so jealous. Can I move there? I'm ready to leave. I think I have a whole line of people.
You wouldn't be the only American at the moment trying to get in.
I know. That's so weird that we're all trying to leave. But anyway, go on.
And they found that there are 19 effective treatments for depression. They're divided into mild and severe depression. And out of that 19, 3 involve antidepressants. They also involve various forms of therapy, exercise, mindfulness. It's interesting that the most cost-effective treatment for severe depression, people think it must be some new drug, it must be a blockbuster, blah, blah, is problem-solving therapy. Problem-solving therapy is where you outline the 3 major problems in your life and the first step to take for each one and report back in a couple of weeks on progress made or barriers encountered. And I think that really speaks to the major drivers of people's mood and anxiety is what's going on in their lives. Now, there may not be simple solutions that you can just, do in a couple of weeks. But I do think that the very medicalized way of thinking about depression and mental health in America especially, all about chemicals, does push people towards chemical solutions. And that's not what the data shows. The data shows that in the long term, things like therapy have better outcomes than drugs, because drugs wear off and therapy teaches you something about how to manage your mind or your life that you can get better at. It's a skill that you can improve, whereas drugs are things that wear off. So, I'm not saying that everyone should get therapy, but, the evidence is stronger for it than drugs. But I do really think that demedicalizing, depression and not thinking about it in terms of brains and chemicals and understanding it that we are, human beings in social networks with circumstances in our lives that determine our mood, would be a very big step forward. I think there's been decades of kind of marketing hitting Americans, telling them, chemicals, the next solution must be a drug. And so about thinking about inequality, thinking about, job insecurity, thinking about all the pressures on young people. Those are the major drivers, according to research, of what makes us unhappy. And so the idea that we could find a drug to solve all of these social problems, all of our individual life problems, I think is a bit, misleading.
No, I think it's so true. I talk about a lot on the podcast because I'm not on a medication, but I say the best medication for me is to go on a walk every day and be outside. I walk by the ocean and I look out at the sea, and that helps my brain, all the chemicals that you release that help. It's like automatic happiness. Even if I am having a really bad day, it always will help. And I always say that to my listeners. I wanted to ask you, kind of a little bit more about Outro. So you said you started it in England and now you've expanded it into the US. Can you tell my listeners a little bit about that?
So I've done something similar in England in the public health system, but no, Outro was originally in Canada and now in America. So okay. Basically after I started publishing these papers about how to safely stop antidepressants, there's a particular technique called hyperbolic tapering where rather than going down to the smallest tablet and then stopping the drug, or like a lot of doctors recommend, going every second day and then stopping the drug, we often give people a liquid. We go down in much smaller steps. I started getting emails from Americans, and I've got about 20,000 emails from Americans now asking me to help them come off their drug. And I was a researcher in London at the time. I thought, there's obviously a huge need because most doctors have been taught, as I was taught, it's not hard to come off these drugs. You can do it in a few weeks. If people get into trouble, it means they probably need the drugs. That leads to this revolving door where people try to come off, get into trouble, go put back on the drugs, and are told don't try again. But there's clearly I think patients have sort of understood it a lot themselves. Coming off, they get brain zaps, these little electric shocks, they get dizzy, they get symptoms they've never had before, like I went through, and they think, this can't be my condition coming back. This is something different. I'm not sure that my doctor gets what he's talking about. And that's why people approach me. And so a group that are good at running clinics, came to me to set up this series of clinics in America, and I was very keen to try to help all these Americans coming forward. And so we've set up clinics that are now operating, I think, in more than 10 states, in New York, California, and a whole lot of states throughout America, where we have specialist nurse practitioners supervised by psychiatrists who are educated in the techniques that are now more common in the UK, but not in the US, about this hyperbolic tapering, coming off in small steps, checking how the person's going. It's a much more, monitored, bespoke process than the usual thing the doctors say, halve it, quarter it, come back in 6 months. So we're able to support people throughout the process. People get into trouble. They can contact us in between appointments. So it's people are much more held than sort of being given very brief instructions. We have a suite of holistic health, things that they can do to support their mental health while coming off that don't involve medications. And I'm very proud of what we put together there. We've got some brilliant nurses working there. We've got some American psychiatrists we work with. We've seen our first couple of hundred patients. And so, we're just expanding things at the moment. And it's, we've had very good outcomes. I guess the main, the headline is that many, many people who could not come off their medications before because of the brutal withdrawal effects they experienced are able to come off in this slower, more supported way. And that's very gratifying to see it all come to fruition.
Well, I love that I'm so happy that you came on today to talk about this, because when your application came through, I remember reading it like a couple months ago and going, it's not like I don't know if it's just like we're so trusting and we're like, well, this is like a fix it. Everything's going to be fixed if you go on this little pill, and it's constantly being drilled into our heads by ads, whatever. And then we're putting our kids on it, like we talked about in the beginning. And it's like something has got to give, and it's what you've said today kind of really has scared me and stopped me in my tracks, but it really makes sense. So I'm so grateful that you've put all of this out there. I wanted to ask also briefly about where people can find your book. And if you could talk a little bit about that.
Outro Health, you can search for it on Google and work out which states it's open in. My book,
Amazon,
Maudsley Deprescribing Guidelines is on Amazon and other booksellers. So you can find it there.
What is the biggest takeaway that you could give a listener of mine that might be right now in their 10th year on sitting on an antidepressant, and they're sitting here listening to this episode going, oh my God, what do I do? I'm scared. What would you say?
I'd say I want to give it a double message. I find it's hard to put both of these in people's minds, but it may not be the best thing for your health to be on an antidepressant for the rest of your life or for many years. And number two, it's not a good idea to stop it quickly, because sometimes people hear me talk or read about things about how, the negative effects of antidepressants, and they get very nervous and want to stop the drugs. It may well be a good choice to stop the drugs. You might want to talk about it with your doctor. You might want to evaluate what the negative effects are. If you do decide to stop a drug, do not do it quickly. That's the way to come off antidepressants, if you want to do it, is to do it gradually, generally much slower than most doctors recommend, not a few weeks. If you've been on a drug for 10 years, and there are 25 million Americans that have been on drugs for more than 5 years, so there's a lot of people out there. The way to come off it is slowly. There's a technique called hyperbolic tapering that makes it a lot safer. It's not just splitting the tablet in half and then stopping it, not taking a few weeks, but often getting hold of a liquid, coming down by small amounts, doing it at a rate that you can tolerate, not that some doctor tells you it's got to be led by the patient. People's experience of withdrawal symptoms is the most important guide. Being very careful at the end, and looking for other things to support yourself throughout the process. Those would be my main takeaways.
And then I would think too that, and again, I am not a doctor, so I'm going to say that, but talk to your doctor, read up on this information. I never want to give medical advice to my listeners. Obviously you are a doctor, but I find this fascinating and is really making me rethink some choices that I may have in my own family. So I'm so grateful that you came on today. Where can my listeners find you?
So I've got a very dinky email page, I think at markhorowitz.org. I work with Outro Health. They've got a much slicker webpage. I'm on Twitter at markhoro, MARKHORO. You've got my textbook. I've got to say one thing that I found, interesting, but also slightly disturbing, which is a lot of people who buy my textbook are patients, and they buy it to give to their doctors so that their doctors will be more informed. To me, that's a big inversion of the way that life should be. It should be doctors buying textbooks. But I think that there's been a lot of, as I mentioned at the beginning, a lack of understanding about how to stop these drugs, and patients are sort of, forced to play catch up, learn things themselves. So patients might be inclined to try that. Or if Outro is in your state, there are clinicians there that know what they're talking about, different from the average doctor out there that people might have had trouble with.
Well, I think it's important that you said that. Everyone that's listening, do your research, read up on things. I mean, I say this all the time. One doctor is not, doctors are people too. People make mistakes. People go to medical school and they, learn the wrong things, or they have their own opinions on things. you just can't rely on one person. You have to do your own research. If you have a gut instinct on something and you're on a medication, I'm very upfront about how I was on Zoloft, and I just felt like I needed to wean myself off of it. I felt weird. I started to have feelings about like, maybe I don't want to be on this long term, and I did. And I'm not saying I'm I'm doing great, but I find ways every day to be able to deal with my depression, my situational depression right now, dealing with grief. And one of the biggest things I talk about is like going outside, doing talk therapy. There's all different kinds of things. So I say all the time to people, the best thing that you can do for yourself is talk to someone. The human connection, get off your phone, get outside, right? I mean, it's huge. That's step one. Dr. Mark, I'm so honored that you came on and you stayed up late. You're in England and I'm in the US, and I know you're probably tired, but I just really want to say how grateful I am to have met you and cannot wait to read up more on what we've talked about today. So thank you so much.
Thanks for having me on, and thanks for bringing attention to this issue. I think your solutions for your mood are very good solutions, and there's good evidence behind them as well. So it's not just true for you, but there's good research behind what you're saying. Being out in nature and exercise, and human connection. So
huge, yes, thank you. So everyone, you matter. Your story matters. Keep going.
Judging Meghan with Meghan Judge.